Hello, my friends. It's Mrs. Surratt. As you can see, I'm up and on my feet and doing a lot better today. I am truly sorry I had to cancel class. I can tell you, actually, in my 3 years of working for GCA, I think that is the first time I have ever had to take a sick day. So, not my idea of fun, but I would like to first thank all of you who sent me such sweet messages or told me to get better in class. I know it was a very short and interesting class, but I just really appreciate all your kindness and concern. So thank you very much. You don't know how much that meant to me to come back to my email and just find lots and lots of take care, get better type emails. So thank you. You guys are really, truly wonderful. So today we are going to wrap up Unit 5. I know it's hard to believe we're at the end. We're going to look at stress and mental health, and we're going to talk a little bit about the treatment of psychological disorders. So as I explained in the last class, we've learned these approaches. We've learned how they've been developed. We've learned the different ways they're used. But now comes the tricky part where we actually figure out what to do with them. So hopefully this will help you with that. Do take a note at what's due this week. There is a lot. There is the 5.04 essay. And I was a little confusing in class, I know, this morning. But I just want to say that with the essay, one of the things it talks about is for you to think about reasons why people between the ages of, I believe it's 14 and 25, but I can't remember at the moment, um, would have depression. And so I was saying that if you feel like you don't really know the answers to some of those, you may need to do a little bit of research, and it doesn't take long. Some of you asked me, can I bring in a personal experience? Absolutely. Keep to the focus of the essay, and there's plenty of times when a personal focus can kind of explain or help others. Also, if you're not sure how to help someone with depression, you might want to do a quick little bit of research. And if you're still confused, let me know. I will have my raise your grade session on Friday at 12:30, so that's a good time to get some help too. All right, so what will we learn today? Well, we will be thinking about how each approach would treat a patient, oh, my tongue's not back yet, and the type of disorder or personality that would best respond to the approach. Sadly, oh, there's our Vision, Mission, and Class Connect Fab 4. I know you live for it. Sadly, we're still not talking about world domination, but hey, that's something you can pursue on your own time. And we will take a moment to say hello to Tabitha, whose slide I was trying to get through when I had to end class. So poor Miss Tabitha, I wanted to give her her due. So this is the lovely Miss Tabitha, and she loves dogs. Oh, I didn't realize that would move. Ha! Look what I found out. She loves dogs, preferably puppies. Her favorite candies are Skittles, which my lovely face is hiding, and gummy worms. She's trying to decide between photography or becoming a vet. And someone suggested wildlife photography, which I was like, hey, there's some of the best of all worlds. Her favorite color is a pastel teal, which sounds lovely. She likes cola. Looks like maybe Coca-Cola. She likes potato chips, egg rolls, and she loves to read and listen to music. So, Miss Tabitha, thank you for sharing. I give you a little round of applause there. It's always great to get to know you guys. All right. So one of the things we want to think about in this class is who actually treats people with psychological disorders. Sometimes I have students who will say to me, Miss, like a psychology degree, like what could I even do with it? And you'd really be surprised. And I had this fabulous video I was going to share with you guys, which naturally they just took off the computer 2 days ago. Thanks a lot. But you'd be amazed at what you can do with a psychology degree. And I'm going to go through some of the big ones here. So let's imagine, who is this person? We're going to play our favorite game show, Who Am I? So I have a doctoral degree, which is a PhD, and a license. I can help treat disorders, but I usually don't prescribe drugs. Who would this be? Pause if you want to think for a moment. The correct answer is a psychologist. So obviously you can start with a psychology degree to become a psychologist and treat people, and I know many of you have mentioned it, which is very cool. Next contestant, I have a master's and possibly a PhD in psychology or counseling with a license. I work in schools or businesses by listening and assisting with everyday problems, but I refer the more serious situations. All right, take a moment to think about it. Pause if you want to. That would be a counselor, a school counselor, or a business counselor. And there's lots of situations in which people are employing counselors nowadays that may not even be on this list. So counselors are definitely one who use a psychology degree. Contestant number 3, please come on down. I went to medical school and specialized in mental disorders. I have a license. I treat disorders, prescribe drugs, and perform operations. So notice, different from a psychologist in that this person actually is medically licensed in that they can prescribe drugs and perform operations. And the correct answer would be a psychiatrist. So note the difference. A psychiatrist tends to perform more neurobiological. They tend to have surgical degrees as well as medical degrees. All right, last contestant. I have a master's degree and possibly a PhD in social work with a license. I help people with everyday family problems, but refer more serious situations. Who would this be? A psychiatric social worker or a psychiatric nurse. So there are nursing or social worker degrees as well that benefit greatly from having clinical psychology degrees. So if you're interested, some people have told me I want to become a forensic anthropologist. I have a friend whose job is a business analyst. She has a psychology degree. She goes into a business. She looks at what people do in their job, how their job could affect them, what kind of person would be most ideal for this job, but also what they need to support them to be better able to do their job. And so she's basically, she doesn't hire or fire anyone like that, but she just goes to companies and says, hey, you've got a department that's failing. Well, here's the situation you've got in there. This is what you need to consider. And she makes a very good living at it. So there's lots and lots of things you can do with a psychology degree. All right, obviously you don't have your polling tools, but I thought it was interesting to consider what would be the most popular approach of psychology in treating disorders. What do you think? Would it be behavioral, just working on the external observable behaviors? Cognitive, working on changing mindsets? Humanism, working on self-growth and self-analysis? Or psychoanalysis, looking at the past to see how it could affect people? So choose in your mind which you think is the most popular approach. And interestingly enough, I'll move myself over here, you can see it's actually what's called eclectic, or a combination followed by psychodynamic, which is another term for psychoanalysis. So these the eclectic, that's like that biopsychosocial, biopsychological, diathesis stress, trying to combine different approaches into the best treatment for somebody. So it's kind of interesting because sometimes you might think there's maybe one way to go here or there, and really what we're finding in psychology is there's multiple ways, but we knew that, right? All right. So we're going to look at the psychoanalytic approach to the treatment of psychological disorders. When is it useful? Remember our friend Sigmund Freud, he believed that disorders come either from childhood experience and or inner conflicts, and I'll get into what that means in a moment. But basically that there's some parts of your personality that aren't working well together, not playing with others nicely. So one of the big things with a psychoanalytic psychologist, try saying that 5 times fast, is having the patient understand the unconscious conflict, which Freud called gaining insight, to help reduce anxiety. Once you kind of know what's fighting with each other, it's like, okay, wait a minute, I think I can work on this. So there's several techniques. Hopefully you remember some of these. The first one being free association. Remember I put on the board stress and I asked you guys to say any word that came to your mind with stress. Well, what the therapist does is asks the patient first to, relax and calm down a little bit, and then says, hey, I'm going to give you a word. Just tell me whatever you think of in your head that goes with the word. And it's not about a right or a wrong answer. But as a therapist, you start listening for a pattern, or maybe the person says something and you say, oh, so it's like this. Oh, no, that's not what I'm talking about. Oh, or is it what you're talking about and you don't know it? So the therapist tries to look for places where the patient could be experiencing an unconscious conflict. Another is dream analysis, the idea of what we have called the manifest content and the latent content. So manifest content is when you see in your dream, like I've used the description of me in my imagining I had a dream where I was riding a motorcycle and there was an alligator on my back. Well, I've never ridden a motorcycle, first of all, and I've been very blessed that no alligators have tried to give me hugs. So obviously there's something more. So that's my manifest content. What's the latent content? And so that's what the therapist is going to look at. What could that motorcycle represent? What could that alligator represent? Perhaps the motorcycle is the path of my life and the alligator is something that I feel like is trying to knock me off the path. And transference. Sometimes you're mad at somebody. You know, we talked about projection and stuff, but you don't want to place that anger on that person. So perhaps you take your feelings out on your therapist or someone else, and the therapist is going to listen and say, okay, maybe there's an unconscious conflict there that you're struggling with and you need to address. Now, what do we mean by this unconscious conflict? What are the parts of the personality Freud mentioned? Remember this, the ego, the superego, and the id. And remember that the id is unconscious. We don't even know it's functioning. Whereas the superego is largely unconscious with a little on the tip, and the ego is the one that kind of rules everything. According to Freud, the id operates on something called the pleasure principle. That means that anything you want, anything you think would make you happy, you want it right then. You do not want to wait. Gimme, 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 gimme. So the id could be hunger, it could be thirst, it could be anger, it could be a sexual urge, it could be a desire for gratification. Mom, buy me that Xbox now, 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 now. The id is constantly pushing us for the things we want. When you're in balance, you have the superego and the ego to kind of keep it under wraps. The ego remembers like our executive functioning. It reminds us of the rules. No, what do we need to be doing right now? Hey, I know you're hungry, but if you just finish this last question, you'll be done. The superego is the one that talks to us about our conscience. You know, that's not the right way to behave. We really need to think about how to behave. So here's when it gets interesting. If you think of the id as the pleasure principle and the ego as the reality principle, well, eventually there's going to be some conflict there, right? I mean, the id's going to want to do something fun and the ego's going to be saying no, and the id's going to go, "Arr!" And there could be some kind of stress. What's great about psychoanalysis is when you have a verbal, educated person and you have a disorder like mild depression or anxiety. Something we can delve into, something we can talk about, but you have to be, as the patient, articulate enough to explain to the doctor what you're thinking and what you're feeling. If you have a patient who's nonverbal or a patient who's not very good at verbalizing, psychoanalysis is going to be really rough for them. So you can see the difference here, the id, the party time versus the ego. Now, what about humanism? I'll just hide that there for a moment. When do we want to use the humanistic approach? In this approach, there's less of a doctor-patient distance and more of a relationship that's almost of equals. So the doctor has, instead of a patient, a client. Okay, so two people who are working together, and the goal is to help the client develop self-awareness and self-confidence so that they can begin to fix their own problem. The therapist and the client are pretty much equal. And the therapist may direct the client and say, you know, well, what do you think about this? What are you seeing here? And maybe the client will say, oh, I never considered that. That's an insight. But the client has the right to say, you know what, I disagree with that, or I'm not going to do it, or yeah, that's a great idea. So it's very much on equal footing that way. Let me see if I move myself into the middle while I block anything. Carl Rogers came up with with what most humanists follow as client-centered therapy. And he said there's three parts that you have to have if you really want to be able to help your client. One is genuineness. It's not just good that the client's open and honest, the therapist has to be too. And that might mean for a therapist revealing something that makes you uncomfortable or unhappy about yourself to help your client make some decisions or some thoughts. You have to have an unconditional positive regard. Even if the client tells you sometimes I have dreams about doing something awful, you need to say, okay, all right, let's talk about that. Let's work on it. You never look at them and go, you what? You always have to be accepting and have empathy. Offer an emotional understanding to the client. I mean, think about it. How many times have you told somebody what was going on and they started to fix something and you're thinking, I really just want you to listen. That's kind of what humanism is about, is listening to your client, validating them in terms of, self-validation this time, not validity of a test, and understanding what they have to say. So before I go to this question, I just want to point out that this is considered a model of humanistic therapy. Okay, so therapy is good when the therapist can focus on the things that they believed about the client that are true, but that are based from what the client has said and told them, and things they know about themselves. I mean, we all have our own beliefs. We all have our own thoughts. We need to be aware. Maybe you have a belief that something your client likes is bad, and you need to keep that in check. Okay, I don't like it, but my client does. Where you get into danger is when you start to explore things as a therapist that you're unaware of yourself or of the client, and you allow some of these negative thoughts or emotions to creep in. And then if you are not really understanding your patient, if you said, okay, well, this is the picture I have of my patient based on what I believe, not what my patients told me, that's where bad therapy comes in. So as a therapist, you really have to stay on this end of the bubble in order for therapy to happen. All right, so according to humanistic therapy, who should decide the problem and the treatment? Do you remember? Do you remember? It's the client. Yes, the client should be in charge. And humanism uses different types of treatment, for example, active listening. So not only do you hear what the client says as a therapist, but then you rephrase and ask the client to clarify. If the client says, no, that's not what I said, oh, okay, please try that again. Tell me what you were saying again to better understand. This is really effective with anxiety disorder, mild depression, or a mild social disorder. But again, you need a client that is willing to talk. They generally need to be a little more educated because they need to start being able to sort out what they believe that they need to keep and what they don't, what's holding them back. Also, sometimes this involves a little bit of homework, and if you've got a client who's not willing to go home and do the work you're asking, not going to work so well. So moving on to the cognitive approach, as we know this is all about thoughts and what's going on in your brain. And there's kind of two schools of thought to the cognitive approach. The first one's referred to as rational emotive therapy, and it's the brainchild of Albert Ellis. And this is the idea that we have a lot of false concepts. When we learn a false concept, it becomes a part of our thinking. And according to rational emotive therapy, if we are confronted with our irrational belief and shown how it's irrational, this can be changed, and then we can start making progress to make ourselves better. The therapist is kind of like a teacher. So they sit down and they say, okay, look, here is this irrational concept. Do you agree it's irrational? Great. How are we going to change it? Well, here are some skills that we can use to change this. For example, if it's a thought pattern, when you recognize that thought pattern, you say, wait a minute, this is the thought pattern. What am I going to say instead? Now, there's another school of thought by Mr. Aaron Beck called cognitive restructuring. And the idea is that instead of challenging the client's thoughts, so with rational emotive therapy, if a client says, oh, I'm not tall enough, so I can't play sports, you might say, wait a minute, that's irrational. But think about it. I mean, when someone tells you you're wrong, your first reaction is, no, I'm not, right? So according to Aaron Beck, instead of challenging the client, say, okay, sure, you can't play sports. I hear what you're saying. And then go through and poke at that thought, poke at the logic behind that thought, and help your client to come to the opinion themselves of going, wait a minute, that doesn't make any sense. I can't do sports because I'm too short. Well, maybe basketball would be a struggle, but there's other sports I could play. So you're trying to help them become more logical in their thinking. And clients will have homework to do. You might ask them to fill out a form about their responses to their everyday life events. You know, stop and at the end of each day, excuse me, sorry, the sneeze snuck up on me. Stop at the end of each day, and now you have to tell us what happened. Okay, you had an incident with your boss. Talk about your thoughts there. So the question is, which disorder we've studied is likely to do well with this type of treatment? And if you think about it, depression, anxiety, even a personality disorder would work very well with this method of testing the logic of your thoughts if you have a person who is motivated, who wants to be involved, and is willing to do the work. Okay, so some patients would be willing to, not everybody. So what else could we use? We might go next to behavioral therapy. And behavioral therapy works very well with a number of different approaches. But as you can see, it's an ABC. So A is the antecedent. What happens? B, your behavior. What is your response to what happens? And C, what is the consequence? And if the consequence is undesirable, that's going to be another antecedent as you are unhappy with that, and it's going to lead you to a problem with your behavior. And so you can see the cycle goes on. So the goal of behavioral therapy is to modify and help people acquire more adaptive behaviors. So let's say the antecedent is your mom says, go clean your room, please. Okay? And your response is, I'm not doing that now, I'm busy. Well, of course, if your mother's anything like mine, the consequence ain't gonna be pretty. So let's say your mother says, go to your room right now, you're done with video games for the rest of the week. Well, that's an antecedent. And you respond by, you can't be the boss of me. And next thing you know, you get this cycle. So the goal of behaviorism is to help you change your behavior to get a more desired consequence. So maybe your mom says, go clean your room, please. And you say, yes, ma'am, but could I have 5 more minutes to wrap up my game? And your mom says, all right, 5 minutes and you go clean your room. And yeah, you still have to clean your room, but you're no longer stuck in this cycle. So this can be used in a number of ways. One's called systematic desensitization. There's aversion therapy where you learn to dislike something that you don't want in your life. Extinction where we end the behavior, or a token economy. So I'm going to talk about each of these. Remember Mary Covert Jones, the little boy Peter, and Peter was terrified of rabbits, and she gave him, remember, candy. Yes, she gave him candy, which was something he had a positive association with, and so she would have Peter become closer and closer to the rabbit, and each time he got closer, she gave him a little more candy, and next thing you know, Peter thought rabbits were the bomb because he had that positive association from the candy with the rabbit. This is systematic desensitization. Sometimes you're afraid of something. That's okay. We all have fears. Maybe you're uncomfortable with something. And so this is a form of classical conditioning where you're going to associate the thing you dislike or you fear with something that you have a more positive or appropriate response to. So the first thing you would want to do is to create a hierarchy. So what is a situation that produces the least amount of fear all the way down to situations that just terrify you? So you're going to start from the top. You're not going to start at the bottom and dive into, something terrifying. And you're going to use some relaxation techniques. Could be something as simple as, here, have a piece of candy and just sit here. But you're going to gradually ease yourself into each situation until you're desensitized. It no longer bothers you like it used to. You could also use aversion therapy. This is often used with smokers. So you replace a positive response to a stimulus with a negative response. Okay, so let's say that you know someone who smokes, and we know ashtrays are really nasty. Where they put out the smoke. It's gross, and so you get them to associate that. Ooh, I really don't like it, or maybe they hate Brussels sprouts, or maybe they dislike, I don't know, slugs. And so you get them to associate that dislike with the smoking, the thing they want to do. And the goal is they pick up the cigarette and they go, oh, no, thank you. And this helps them to break the cycle of smoking. Oh, there is your cycle 3, week 3 ticket out the door. password. It is schizophrenia, lowercase. Make sure you spell that correctly. Take a moment, pause if you need to. Make sure you get down that password, schizophrenia. All right, let's talk for a moment about extinction techniques. Sometimes you want to end a behavior. You just want it gone. For example, if you think about a kid who maybe pitches temper tantrums, okay? If you remove what the child wants, then it's going to eliminate the behavior. So for example, every time the child pitches temper tantrums, everyone starts paying attention to him. Oh, Bobby, don't cry. You know, if you do what I ask you to do, I'll get you a lollipop. Well, Bobby's getting it pretty good, right? So if you remove the attention, just pretend Bobby's not there. You don't notice a child on the floor screaming and crying and kicking, and you just go about your daily life. Bobby's going to realize, and it's not going to be right away, by the way. You know, especially when you're dealing with someone of a higher intelligence level, they're going to keep at it to see if it works. They have to keep testing that limit. But eventually, Bobby's going to say, wait a minute, I'm throwing myself on the floor, kicking and hollering, and then I'm still having to go do what I was told to do. This probably is not working. So the behavior should become extinct. And a token economy. So people are put into organized settings and they're given an appropriate, they're rewarded with appropriate behavior. This tends to work when you're talking about like a classroom. Yeah, how about an elementary school? Do you ever have a teacher who, oh, I'll give you a class dollar when you do something off this list? Or if you're in like an organized institutionalized setting, you know, these kinds of behaviors earn coins. These kinds of behaviors take away coins. If you get these kinds of behaviors and you earn coins, you can trade that up to a larger reward. Again, where would behavioral therapy work the best? Phobias, PTSD, and compulsions do very well, especially with aversion therapy and systematic desensitization. Also, extinction and token economies, you know, every time you can control yourself, that you take a deep breath and you get a little closer to that target behavior, we use some shaping with that token economy. Also, people who live in institutions like a mental hospital, especially schizophrenics, tend to respond very well to a token economy. It's a very physical reminder of doing the right thing. You know, if I say to you, good job, well, you feel that, but sometimes having that item that you can look at and hold and say, hey, look, I earned this, it provides you with a little bit of pride and a reward. All right, move myself over here. Thinking about neurobiological therapy. Neurobiological therapy almost always involves things like drugs, some type of drug. And if you want to think about what can the effect be on psychological disorders like depression, anxiety, personality, or mood disorders, they can be positive in that they can help the patient keep those issues under control or begin to feel less affected by them so they can start using other therapies to move forward. But unfortunately, there's also side effects. If you think about many medications do have some side effects. So neurobiological therapy includes drugs, electric shock, and surgery. Now, I'm not talking about if you've ever seen one of those old-fashioned movies with the light bulbs coming out of someone's head, shocks. We're not talking about anything like that. Believe it or not, a minor amount of electricity actually can be helpful. But drugs are typically the most common therapy used in neurobiological. And there's 4 major types of drugs that I'm going to talk about. The first one being anti-anxiety. And anti-anxiety drugs actually work by depressing the activity of the nervous system, especially that fight or flight system. It just kind of dampens it a little bit. So they can't cure anxiety, but they can reduce the symptoms. And when a person starts to feel anxiety, it's like, oh, wait a minute. All right, let me get control of this situation. Antidepressant drugs. You know, we talked about how depression is the common cold of most disorders. Well, antidepressant drugs are actually quite common, and they treat depression. They can help with eating and panic disorders, and again, they work by dampening or limiting the production. I'm sorry, the opposite. They increase the production of neurotransmitters such as serotonin and norepinephrine. So they work by dampening that system, that fight or flight system, but then they also increase the amount of neurotransmitters that are in the brain, because oftentimes that's what's actually causing the depression is breaks in those um, oh, come on, brain. Neurotransmitters. I'm sorry. My brain just shut down there, apparently. But patients do need to be watched, especially as they start getting on higher doses. Most people are put on fairly low doses, but you don't want to overdose. All right. Talking for a moment about lithium carbonate. Lithium carbonate is very useful for helping to flatten out the cycles of mania and depression. So instead of swinging way up high for the mania and dropping way down low, it just kind of drops the swing. Unfortunately, lithium is really helpful for that, but it can have shakiness, memory impairment, and excessive thirst as its side effect. So it's definitely one that is helpful, but also difficult to spend a lot of time on. And then last but not least, antipsychotic drugs. Major tranquilizers are included in this. They are very effective, especially for schizophrenics in reducing agitation. You know, when they get really worked up, delusions, hallucinations, they help them kind of focus in the real world. And some antipsychotic drugs have been found to block activity of dopamine, which reduces symptoms of schizophrenia and Parkinson's disease. So somehow dopamine is linked in there. We're still not 100% sure how. Of course, the other side effect is sometimes it gives you this sort of, uh-huh, yeah, flat effect. Like you're not really reacting to anything. People may think that when you're on it, you're kind of out of it or you don't care, when in reality, the drug is doing that to you. Of course, if you can function in the real world and not have hallucinations, it's a catch-22. Now, I want to mention something called electroconvulsive therapy. This is something that is not a first resort. It's typically used after other drugs and other methods have not been successful. And when it was first introduced, it was horrible. Okay, people were just shocked, and they'd break teeth, and they would cause all kinds of problems with their nervous system. Today, we do know that electroshock therapy can help your brain. It can kind of reset your brain's electric patterns, but it has a lot of negative side effects. So we use it again as kind of a last resort, but there's anesthetics that are administered. Like they use a jaw protector to help the person who's going through it, and it's used with the permission of the patient. That didn't used to be the case. But there are times when people are suffering things from like major depression, major depression, and nothing else has worked. They might try a little electroconvulsive therapy. It's not meant to be a long-term treatment. It's meant to be a few treatments to kind of get you back in place. I think some seizure activities have shown to be useful for this too. But again, it's not your first course of action. Unfortunately, guys, there are some people who nothing has worked and they're stuck with this and it's taking over their life. And that's when you go to something very radical and something very rarely used, which is psychosurgery. So think about the thalamus. Remember our thalamus, our friend who receives all the signals from the different senses and sends it out to the different places it needs to go. It's involved in the wake and sleep cycle. Our thalamus, sometimes it gets overstimulated or it's not doing its job and everything gets stuck there. And it works with the prefrontal cortex. And the prefrontal cortex is involved in all that complex planning and cognitive behavior, our expression of our personality, the decision making we do, and how we behave in social situations. So when there's issues of the thalamus and the prefrontal cortex trying to work with each other, and maybe one's overloading the other or one's not able to receive the signals of the other, sometimes the best thing to do is to separate those two. I know it sounds horrible, but sometimes it's the only way. And this is when you can use a brain surgery called a prefrontal lobotomy to separate that frontal cortex from the thalamus. Again, never your first choice. Always the choice when you have no other choice. Side effects can be distractibility, apathy, seizures. You're not able to really plan or to make decisions. You might have trouble caring about things or getting interested in things because you no longer have that prefrontal cortex involved in what's going on. Again, this is more controversial than electroconvulsive therapy. It is rarely used, but I have met some students who've told me that they or family members have gone through it and it was a huge benefit to them. But once again, it was the last resort. All right, so I'm going to shoot through this here, matching the treatment to the approach. Make sure that you're able to do that. Sorry, I'm trying to find the best place for me to sit and not be in your way. But notice that psychoanalysis uses both free association and dream analysis. Behaviorism uses both aversion therapy and systematic desensitization. And then psychosurgery, even though technically it's neurobiology, it's so specialized, it's considered kind of its own thing. All right, our cycle 3, week 4 ticket out the door, which is treatments. It deals with schizophrenia. And it talks about the sufferer of schizophrenia and what they could go through: delusions, hallucination, disorganized thinking, and an inability to motivate yourself, poor eye contact. And I want you to consider these three approaches, sorry, of psychology. Sorry, again, my brain quit. And think about which one do you think would work the best with a schizophrenic. Now, you might think, well, hey, I would say neurobiology and behaviorism. That's okay. Tell me why. And then think about which one do you think would not be useful. And if you think about it, humanism really isn't very useful for a schizophrenic because they don't have the ability to control their delusions, their hallucinations, their disorganized thinking. They can't stop this, and so they couldn't take control of it to move forward. And whereas with neurobiology, they might be able to use like a drug, like we talked about, an antipsychotic, to gain some control and then move forward. Or behaviorism, they might be able to use like a token economy or extinction to begin working on certain behaviors. So just something to think about. All right, my friends, brace yourselves. We are at the end of the semester almost. Can you believe it? Next class, we have the 5.05 test to review for. Class after that, we'll start reviewing for the final exam. Can you believe how fast our semester goes? Next week on Wednesday, I will be in training because all the teachers will be in training. So exciting. December 6th. So just be aware of that. I will see you Monday, not Wednesday. Oh, sorry, that's where I needed to stop. Never mind, but just think about how you could use what you've learned in psychology to help you with your life. So thank you, my friends, again. Thank you for your understanding. I'm really sorry today didn't work out, but I look forward to seeing you guys next week. Have a wonderful weekend.